I'll do my best even shorter.
Oh, lovely. Thank you. Thank you very much.
Sure.
The floor is yours.
Thank you very much. يعطيكم ألف عافية. Of course, Dr. Salwa is a close friend. We've been working together for so long بالArab division of the International Academy of Pathology, and I'm so proud of her friendship. So, دكتورة منال طلبت مني أشياء specific. So I prepared for you as we agreed on. In neuropathology, challenging cases and the role of methylation. Let me tell you something لأنه يمكن المethylation something that is new, and it's like everybody thinks it's like a magic. بتحط الكيس بالclassifier بالeye scan, and then the classifier and تشخيص will pop up. Definitely this is not the case. Message number one, you need always to correlate with pathology لأنه الclassifier can make mistakes. I have 12 cases of straightforward GBMs that were classified as normal by the classifier. It takes, كنت أحكي للدكتورة إيمان, it takes 3 seconds for a pathologist يحكي عليها GBM, الclassifier سماهم normal. Okay, so you have always to correlate with pathology. Number two, it is a magic tool, but not in all cases. يعني if you have limited resources, and our countries all have limited resources, you don't need to run them on each and every CNS tumor or even sarcoma case, as is implied from literature. Adult patients, 55 years of age or older, IDH wild type by immunostain GBM, it will always remain the same diagnosis. Hardly ever the diagnosis has changed. Posterior fossa ependymoma, all you need is immunohistochemistry for H3K27ME trimethylated, and it will classify it into A and B. No need for methylation. IDH mutant oligodendroglioma, if you have 1p19q and CDKN2A bifish, you don't need to run the methylation. And there are several examples. Meningiomas, I know that it's becoming very hot. Meningioma classification, molecular, female patient, classical grade 1 meningioma, you don't need to methylate. So it is a magic tool, but it's not, you don't have to spend $1,000 الكوست عنا $1,000 to run the methylation, and this is actually يعني احنا بنبيعه التست ب 1,700 دينار أردني $1,000, and the cost علينا is almost تقريب كتير. We don't make really a profit out of it. So I really بعد أنا صرنا we've been running methylation now for CNS tumors and sarcomas for 2 years. April 2024 we started almost routine, and لحد a couple of months ago it was run on each and every CNS tumor case عندنا بالمركز. But really لأنه صار في لها lots of implication, the cost, the turnaround time, وصاروا خاصة radiation oncologists يأخروا علاج المريض عشان بيستنوا الميثيليشن لأنه ممكن يتغير التشخيص. This has lots of implication. So I made an algorithm I shared with them بهدول الكيسز that أنا بحكي لك wait for the methylation, وفي الكيسز that I tell you I'm not going to do the methylation. Just start treatment based على immunohistochemistry, وطبعاً preferably يكون في sometimes الفيش. Apart from that, really, I can share with you the algorithm that I've created in our cases, in our resources. أحكي لكم بكل العالم resources because it's really expensive. واللي بتطلع على literature بيحكي إنهم they run it turnaround time 7 working days. It is not. The minimum is 21 working days because you have to patch cases. غير هيك it becomes even more expensive. So to be realistic, ننزل من cloud 9 زي ما بنحكي على real world. You don't have to do methylation on each and every case. بشكل عام let alone our circumstances where we have really limited resources. عشان هيك we have to be wise. And I'll show you هدول examples where methylation really made a difference. Okay, so المسج تبعتي إنه methylation makes a difference بس مش بكل الcases. You don't need to do it بكل الcases. طيب بسم الله. Case 1, 4-year-old male patient, right frontal mass. Right frontal, إيش الكلمة هون؟ mass. And this is the low power magnification. أول إشي بخطر على بالنا is it oligodendroglioma مزبوط بتشبه oligodendroglioma. The cells are uniform, growing in sheets. We have the vessels here in between as if there is a clearing around the tumor cells على high power magnification, very monotonous. Again, we have somehow not the typical chicken wire blood vessels, يعني قريب منهم but not the typical, and this is on high power magnification, again showing the same. And this is the chicken wire vessels. Remember oligodendroglioma زمان before the methylation or before كل الانفنشنز in neuropathology كنا نحكي oligodendroglioma بالأولاد الصغار in pediatrics are usually 1p19q negative مش co-deleted. They don't show the co-deletion. ليش؟ لأنه probably they are not oligodendrogliomas. Okay, but this is لو حطينا نفس الصورة بان adult patient 35 years of age, I would bet money إنه this is oligodendroglioma. Other areas showed this myxoid degeneration in the background, and once you have myxoid degeneration, always keep at the back of your mind some of the new entities, but also ATRT, بالصغار. Always remember, a brain tumor, myxoid background, regardless of morphology, always keep atypical teratoid rhabdoid tumor at the back of your mind, and this is more or less showing the same. There were some areas, surprisingly, that showed rosette formation. So we have like several morphologies, pseudo-rosette, let's say, to be more accurate. So we have this vasculature and then the arrangement of the tumor cells. اللي بدكم إياها zone, nuclear free zones around the vessels with tapering ends. We have to think of ependymomas. One very important clue, there was a sharp demarcation. The tumor appeared to be well circumscribed. Again, some myxoidish background, very much resembles oligodendroglioma. Now, GFAP, positive focally, especially around areas of pseudo-rosette formation, but most of the tumor was actually negative. I have to say that there were scattered mitotic figures in the tumor. مع cellularity, يعني we were more inclined towards a higher grade tumor. OLEG2, positive, again confirming or supporting this is a glial tumor. EMA, we thought of ependymoma, especially مع الrosettes اللي موجودين, so EMA was completely negative. OLEG2 is positive, so ependymoma becomes less likely. Synaptophysin, remember synaptophysin is usually positive in the synapses in the brain. So this is not a positivity, this is just in the background, as if the tumor, at least focally, is infiltrative. P53, this is wild type, where you have some positive, negative, and variability in the staining intensity. And Chi67 is increased. This is an important clue that I always try to teach to my residents and students. You know, Chi67 is usually, it's a nuclear stain, مظبوط. Now, sometimes when you see some cytoplasmic granularity, this is mitosis detected by Ki67. Try it, it's very helpful. You can count mitosis, بدل ما تعدوا على H&E, you can count it actually on the Ki67 once you know this very small trick. So, our diagnosis was high-grade tumor. We were not able to reach a definite diagnosis, await DNA methylation. And so, what we do, مثل ما حكيت لكم, إحنا we've been running methylation for 2 years. يعني من تقريباً 6 months, we've been routinely using the DKFZ or the epignostics, هيك اسمه هلا Heidelberg Epignostic Classifier for the methylation. But I also learned how to use the NIH-based classifier, and this is also available for free. And this is the epignostic classifier. Remember, عشان أكون confident من diagnosis, لازم يكون calibrated score هو 0.9 or more. Okay, وقتها بكون أنا confident of the diagnosis. عشان هيك هو هون بحط عند الانتربريتيشن الكلاسيفاير بحط اكس، يعني هو ما بتحمل نتيجه اذا انت اخذت هذا التشخيص، هو بيحكي لك I'm not confident of the diagnosis. اوكي سو ايش شخصها؟ سماها low grade glial glioneuronal tumor. He favored extraventricular neurocytoma or diffuse glioneuronal tumor that is non-defined. The calibrated scores بشكل عام are low. بس remember شو حكينا we have always to correlate with pathology. عشان أحكي عليها نيوروسايتوما لازم يكون فيها strong diffuse synaptophysin positivity. هاي synaptophysin positivity اللي ورجيتكم إياها it's not the strong diffuse of a neurocytoma, so we have to be careful. الكلاسيفاير كمان بيعطيني copy number variation. الميثيليشن is epigenetic phenomenon مزبوط. الدي ان اي زي ما هو وبيجي عليها الميثيل جروب على certain site على السيتوسين in the CBG islands وswitches on and off the expression of the gene. الستركتشر ما تغير. الكوبي نمبر variation profile is the structural changes in the DNA. يعني هاي بونص بيعطيني اياها الكلاسيفاير. بيحكي لي هون it's very easy to read once you know the concept. It's algorithmic. هذا خط الصفر هو خط we have balance. This is the chromosome. كل واحد من هدول short arm and long arm chromosome 1, short arm long arm chromosome 2 and so on لحد ما نوصل للXY. شو بيحكي لي هون؟ بيحكي لي أي إشي below the zero is deletion. أي إشي above the zero تقريباً around ال 4.4 الالجوريثم is considered to be amplification. So هو شو بيحكي لي؟ بيحكي لي there is loss of 1p, deletion of 1p and there is gain of 1q. هيك معناتها الكوبي نمبر variation. None of هدول التشينجز بيمشي مع لا extraventricular neurocytoma ولا إشي تاني. طيب حطيته على ال NIH مثل ما حكيت لكم. طلع التشخيص فيها intermediate grade IDH wild glioma. The classifier is 0.9 sure of the التشخيص and the diagnosis is actually diffuse leptomeningeal glioneuronal tumor. اوكي وحتى الدي كي اف زي ما جابش سيرتها هذه بالمره. ونفس الكوبي نمبر فاريشن اعطاني اياها there is loss of 1p gain of 1q. ال NIH in addition to the classification الميثيليشن classification and the copy number بيعطيني حاجة اسمها اليوماب. اليوماب is a way to locate the tumor تبعي among the group اللي بتشبهه. It's extremely helpful, extremely useful. So this is هي رقم العينة تبعتي R7106. هي رقمها. هيها هون R7106. حطوا مع هذه الجروب اللي هي نفسها الديفيوز ليبتومينينجيال glioneuronal tumor and بيعطيني another kind of يعني it fragments كيف هو وصل للتشخيص هذا، كيف وصل لهذا التشخيص to the suggested diagnosis. Okay. So based على هذا التشخيص الديفيوز ليبتومينينجيال glioneuronal tumor هل المولكيولر الكوبي نمبر فاريشن بيمشي معاها؟ Absolutely yes. لأنه ال 1p deletion is the molecular signature for the diffuse leptomeningeal glioneuronal tumor. في منها molecularly two types, type 1 و type 2. type 2 بيكون في gain of 1q. So المورفولوجي بيمشي معها 100% بيمشي معها morphology, age, classification as per the NIH classifier, copy number changes, UMAP classification beautifully. بضل إشي وحيد ما بيمشي معاها هي إنه diffuse leptomeningeal glioneuronal tumor by definition according to the WHO it presents as diffuse leptomeningeal disease without well-formed mass. هذا التشخيص تبعها diffuse leptomeningeal glioneuronal tumor. However هذا اللي حكيت لكم عليه group 1 بتكون typically 1p loss. This what really defines this group of tumors. group 2 بيكون معها 1q gain typical and it's more aggressive. And this is the CNS5 classification. The tumor إذا بتطلعوا عليه بيشبه كتير our tumor. Usually G5 بيكونوا negative زي ما كانت عنا. OLEC2 بيكونوا positive زي ما كانت عنا. بتكون well circumscribed زي ما هي موجودة هون. بيكون فيها myxoidish degeneration exactly like our case. الإشي الوحيد presentation تبعتها. However diffuse leptomeningeal glioneuronal tumor a double misnomer. لأنه there are many cases now in the literature that they are presenting as masses and they are not diffuse ومش based على بالleptomeninges, they are intraparenchymal. Exactly like our case. And again, these are two cases that they shared, and look at the 1P loss, diagnostic of the entity. So I think بدون methylation we could have not reached into the diagnosis, and it is in these cases in which the methylation really adds value. ليش؟ لأنه هدول tumors usually are BRAF positive, the patient can be treated with targeted treatment. So the whole management has changed in such a case. أي سؤال على الحالة الأولى؟ تفضل. Usually, it's not always. Yes.
حضرتك يعني عملتوه وتاكدتوا ان هي diffuse leptomeningeal.
Yes, this is the typical. We have a fusion. Yes, we did it actually. Complementary مثل ما حكيت لكم. What we do ما بنعتمد بس على التشخيص اللي بيطلع من الميثيليشن إذا كان contradicting to our initial تشخيص. We follow up with more testing and we have actually the probe for the fusion, BRAF fusion, وطلع فيها الفيوجن positive. Because of that, the patient is subject to, was entitled to take a targeted treatment.
شكرا.
Okay, أهلا وسهلا. طبعا هو mostly الفيوجن بس ممكن يكون في BRAF mutation وممكن يكون في other types of BRAF fusion غير عن the classical fusion. أي سؤال تاني؟ طيب 9-year-old male patient. It was posterior fossa mass. It was located in the fourth ventricle with some attachment to the vermis. وهاي الحالة actually إجتنا أول ما إجتني consultation from المستشفى بكينج عبد الله University Hospital بإربد بالشمال. We started working on it. الدكتورة كان تشخيصها إنه this is kind of unusual ependymoma. ودكتورة ميساء إيش رأيك فيها؟ أنا هلا رح أحكي لكم إيش صار فيها الحالة. So this is the H&E. As you can see, يعني why not? تزبط ependymoma. There are perivascular pseudo-rosettes موجودين على higher power magnification. النيوكلياي look okay. كان فيها increased mitotic activity. كان فيها what appeared to me at the time as a true canal. So ليش لا تزبط كتير إنها تكون ependymoma. اللوكيشن الage كلها بتزبط. And again more of the same. هدول هم من الcanals that initially إحنا شفناهم. And there were some areas that were more solid looking. أكثر ما يكون فيهم هذا الروزيتس اللي كانوا واضحين, but they were not the predominant component. And there were areas of necrosis and some calcifications. Mitosis كان موجود. Surprisingly أو هيك interestingly actually كان في حوالين some of the vessels histiocytic infiltration. بس again هيك بيعطيك انطباع إنه في some rosette formation. This is the GFAP positivity, highlighting even some microvascular proliferation. Tumor cells are positive. EMA was disappointing, وهذا هو السبب اللي خلاها تبعت لي إياها. بالنسبة إلها إبانديموما، أنا بس شفتها حكيت عليها إبانديموما. I repeated the immunostain. غريب كتير إنه حتى الترو canals they were kind of negative. كان 5.2 showed only scattered positive cells. فكرنا دائما بالصغار بصراحة أنا بخاف كتير من ATRT بالposterior fossa, so I always incline to do some stains. Chi67 is increased, and again remember الأشياء اللي زي هيك هم من Chi67 proliferative cells. بس cells that show this هذا النقط الموجودة بالسيتوبلازم, this is mitosis in Chi67. So التشخيص كان high grade tumor. I favored posterior fossa ependymoma. حكينا مع الأهل مش سكان عمان مش موجودين عندنا. البيشنت أصلاً مش بكي HCC مش بكين حسين كانسر سنتر. قلنا لهم إذا بتحبوا we have a study that you consent, we take a blood sample from the patient and then we undergo methylation for the patient. If you are interested, الأهل كانوا very much interested. What do you think the diagnosis came back as? والله nobody looked, مش ependymoma. So to my surprise, the diagnosis came back as papillary tumor of the pineal region, calibrated score 0.99957. And I was, what? ماشي حكيت مع الدكتورة قلت لها يا دكتورة نسرين البيدياتريك oncologist. لا حكينا أول إشي مع الدكتورة اللي في إربد قلت لها يا دكتورة طلع هيك التشخيص البيشنت عنده any previous history أي ليجن قالت لي ما في الباينيال gland قالت لي as far as I know this is normal. Let's review the radiology. They reviewed the radiology. Pineal gland normal فيها البوستير fossa mass. The patient subsequently was referred to KHCC. عنا يعني إجا عنا. They reviewed the pathology. We reviewed the pathology. They reviewed the radiology مرة تانية. It is ما في أي lesion تاني but the posterior fossa mass lesion. So مثل ما حكيت لكم epignostics is the usual classifier that we use, but I always بهدول الحالات بحطه على ال NIH classifier. طلع التشخيص pineal region tumor and retinoblastoma يعني region in the pineal gland tumor in the pineal gland region 0.985 and it's papillary tumor of the pineal region group B and this is the calibrated score in front of you. We'll call the copy number variation is exactly the same. ومثل ما حكينا اليوماب هي حالتنا وهيهم المجموعة التيومر هدول papillary tumor of the pineal region A papillary tumor of the pineal region B قاعد هناك. And this is the class details where they dissect how they reached into this calibrated score ولا في أي مشكلة عليه. So the final diagnosis in this case اللي ما فيها tumor ولا lesion in the pineal region is pineal region tumor, papillary tumor of the pineal region. Morphology, would it fit? افتحوا WHO. Exactly. Pseudopapillary areas and solid tumor growth وطبعا it is grade 2 or 3 exactly. إذا هلا بورجيكم الصور. Now I went back and looked على هدول اللي كتير أنا حيروني اللي هم كانوا زي الترو canals and to my surprise طبعا أول مرة أنا ما شفتهم هم actually vascular spaces حواليهم some edema وبعدين الكانالز. Now وين السكشن بيجي مرات ببينوا as if they are empty زي كأنه ما فيهم إشي. بس these are what I thought were the true canals. عشان هيك هي ما أخذت EMA بالمرة ولا دوت لايك ولا أي شيء. So it's a neuroepithelial tumor combination of papillary and solid areas. هذا definition of the WHO with epithelial-like cells and immune reactivity for cytokeratins. This is why we did actually بعدين الكام 5.2 ما كنا عاملينها أول مرة. It's either grade 2 or grade 3 and this is هذا صورة WHO exactly like our case بالضبط. Sometimes the papillae are so prominent بس غالباً بيكون في عندكم this combination of papillary and solid areas and the essential criteria papillary growth pattern and immunohistochemistry for cytokeratin and CD56. So CD56 we did it and it was positive. And location in the pineal region, but it's not ours is not located in the pineal region and for unresolved cases confirmatory DNA methylation profiling. And إحنا ولا خطرت على بالنا لا من قريب ولا من بعيد because the location is not the typical location. So papillary tumor of the pineal region, it's a rare tumor first described ب 2003 recognized in the WHO ب 2007. It's rare. أنا شفت بكل حياتي العملية هاي رابع حالة بشوفها. Accounts for 0.4 to 1% of primary CNS tumor, positive for cytokeratin, nestin, S100, NSE, كلهم non-specific stainings بصراحة. EMA and GFAP typically weak or negative, مهمة كتير, and Ki-67 labeling is variable depending on the grade of the tumor, and then you can see بس هو الأساس فيها location of course. This is where it all starts, and then you can see the different staining patterns. أي سؤال؟ أنت عندك سؤال؟ يا تفضلي.
حضرتك عرضت الجدول بتاع الاسينشال كرايتيريا، منها ان هي يكون اللوكيشن باينيل، سبيشال الهيستوجينيسيس بتاعها لو هي طالعه من الكوميشر من جت منين؟ معلش انا سوري الموضوع، يعني عايزه اعرف ازاي نكتب دايجنوزز المفروض ان هو سبيشاليزد تو سبيسيفيك سايت، يعني this is okay ولا لا؟ بلس انا عايزه بس ارجع للانترودكشن اللي حضرتك قلتيها، عندي بس another question. حضرتك بتقولي لازم نعمل selection للكيسز that we're gonna send for methylation. مش لاقيه بيبر بتقول، يعني لقيت واحده بس مش بتقول بالظبط انهي cases that we should send
And
for
I will
methylation.
tell you.
فانا I need فعلا، لان احنا عايزين نعرف انهي اللي نبعتها، خلاص نقول للعيان ان هو he needs.
أنا رح أحكي لك بآخر المحاضرة.
Thank you.
مزبوط دكتورة حكيك إنه this is of the essential criteria, but with methylation, for example, you know there هلا صار في several case reports of medulloblastoma supratentorial. مزبوط. فهي if it's embryonal tumor and it's classified as medulloblastoma because of the epigenetic or molecular signature, you have to call it medulloblastoma. So there are some odds to the classical way we think of tumors. يعني again, methylation عمل revolution in the classification of CNS tumors, and sometimes maybe this is along the lines, ممكن في a drop of or remnants of embryology of that of the pineal gland along its ascending line into ضلت بالvermis. But definitely we're seeing أشياء غريبة عجيبة with the methylation, and you go back to the morphology, does it fit? Immunohistochemistry, does it fit? Then this is the case. وبعدين ما قدرت أشخصها بأي طريقة تانية، وما الكلاسيفايرز التنتين they were confident، يعني ما في ومورفولوجي it fits وimmunohistochemistry it fits. ضل اللوكيشن هذا مش مشكلتي، يدبروا حالهم هم. أي سؤال تاني؟ هلا رح أحكي لك بالأخير my recommendations. أي سؤال تاني؟ طيب. Last case is case 3 ب 2005. This was my case. At that time, she's a Yemeni girl, عمرها 15 سنة, عندها posterior fossa mass, and this is, I will go through it quickly. Pyloid cells, هي الشعر تبعهم, هي rosenthal fibers, هي كتير حلوة. أنا دايما بحكي rosenthal fibers بيشبهوا الفنجاي, fungus structures, so this is rosenthal fibers, some hyalinized vessels, biphasic tumor, so this is like the microcystic areas. So تشخيص إيش؟ بايلوسيتك أستروسايتوما، وفعلا كان تشخيص بايلوسيتك أستروسايتوما، والمريضة ما أخذتش علاج at that time, nothing, it was completely gross total resection، وتسهلت على اليمن وانتهى الموضوع هناك. Now a couple of years ago دكتورة يمنية تدربت عندنا في الأردن اسمها دكتورة إيمان، تبعت لي إنه هاي المريضة بنت عمتها رجع في تيومر exactly in the same location بعد من هديك 2005، إحنا 20 years later تقريباً، she thinks of a diagnosis وبدها تبعت لي الحالة to look into it. فبعتت لي الحالة radiology والباثولوجي والبلوك سلايدات والبلوكات، I retrieved the سلايدات من تبعت 2005 أوكي اللي هن ورجيتكم إياها، اللي صورناها ورجيتكم إياها. So this is 2024. صارت 32-year-old female patient, recurrence of the tumor in the posterior fossa. So it is a tumor, في pleomorphism واضح. Again هون صار more pleomorphism زي كأنه في vascular proliferation, pleomorphic tumor, eosinophilic granular bodies, again more of the pleomorphism, mitosis was abundant, very highly cellular, it looks like صارت هون زي كأنها embryonal tumor, more aggressive and more cellular and more atypical tumor, microvascular proliferation again, and large areas of necrosis. اوكي سو حكيت لها كنا وقتها يعني احنا تقريبا في بدايات الميثيليشن، and at that time I used to do some cases هيك out of interest ما نحاسب عليهم عشان بس to build up the experience. سو عملنا ميثيليشن على التيومر تبع 2005 وعلى التيومر الجديد. هذا بالدي كي اف زي at that time ما كانش لسه اسمه ابيجنوستكس، كان اسمه دي كي اف زي اونلي. التيومر تبع هيو بايلوسيتك استروسايتوما تبع 2005 طلع بايلوسيتك استروسايتوما، وتقريبا الكوبي نمبر از فلات بنسميها، ما فيش فيها شيء. اذا بتطلعوا هون هذه هي البيراف فيوجن، هيها اوكي. البيراف فيوجن what happens فيها انه بيصير فيها بيراف فيوجن and an extra copy of the بيراف، فعشان هيك بالكوبي نمبر بتصير شوية أعلى من اللي حواليها الجين مش الكروموزوم only the gene. and this is التشخيص اللي بعثته الدكتورة من اليمن واللي I think it was correct، وعلى هذا الأساس كتبناه high grade glioma with أو astrocytoma with pilioid features، and طلعت high grade astrocytoma with pilioid features 0.99 okay. وأجين هيو البيراف تقريبا نفسه. And the hallmark for this diagnosis is homozygous deletion for CDKN2A. And it shows بالcopy number variation بالميثيليشن بتورجيني CDKN2A homozygous deletion، بيكون الجين هيك دب لتحت، واقع لتحت. بس مش بس هيك، رحت recently كمان حطيتها على ال NIH، قلت بدي أتأكد تماماً once I started using the NIH. So this is the pilocytic astrocytoma, posterior fossa pilocytic astrocytoma، هذه تبعت 2005. and هي اليوماب هيها قاعدة مع خواتها posterior fossa pilocytic astrocytoma. والجديدة اللي بعدين صارت intermediate grade glioma consistent with high grade astrocytoma with pilioid features. and هيها قاعدة مع خواتها، هي حالتنا 1504 and this is high grade astrocytoma with pilioid features. and it shows هون مش كتير واضح، it shows the CDK the BRAF بالبيناين وبيراف بالمالجنانت، وهي CDKN2A على كروموزوم 9 هون ملوش إشي، وهي هون على كروموزوم 9P هيو dipped exactly the same confirming the diagnosis. طيب ونحن بنعرف انه ال high grade astrocytoma with pilioid features 50% of the cases بيكونوا ATRX lost. This is the pilocytic astrocytoma and this is the more recent one. هي ال internal control وهي ال nuclei are negative of the tumor cells for the ATRX. So we have CDKN2A deletion and we have ATRX loss consistent with the diagnosis that was confirmed or suggested or rendered by the classifier. So high-grade astrocytoma with pilioid features, this is a tumor diagnosis that can only be made by methylation. It can be suggested لما يكون في عندي ATRX loss مع CDKN2A homozygous deletion. However, the confirmatory diagnosis عشان تكون متأكد منه is only through methylation. Remember that it can occur in the posterior fossa وممكن تكون supratentorial. This is where the difficulty بالposterior fossa لسه الواحد بيفكر فيها. Supratentorial يمكن ما يفكر فيها. Initially described in 2018, added to the WHO in 2021 يعني the more recent اللي هو CNS5. وإذا بتطلعوا على الكرايتيريا هلا بنشوفها it has to have methylation. زمان كان كتير ناس يفكروها إنها anaplastic pilocytic astrocytoma and I think personally it is. Median age is 40. قريب من it occurs in the adult، ما بتصير بالصغار. more likely in females. It can occur in the posterior fossa but also supratentorially the thalamus and the spine. ممكن كتير ناس كانوا يخربطوها زمان بالGBM. It can arise de novo or from pre-existing pilocytic astrocytoma, especially إذا أخذت radiotherapy. But our case did not take radiotherapy with a latent period of more than 10 years. DNA methylation profiling is the only method for definite diagnosis of high-grade astrocytoma with pilioid features, and it shows typically the MAPK pathway mutation. In this instance كانت ال BRAF, ال ATRX loss in 50% of the cases, CDKN2A B loss, homozygous deletion very common in most of the cases. Okay? And this is the WHO, essentially criteria and astrocytic tumor and DNA methylation profiling. You cannot establish the diagnosis without methylation. Desirable criteria are the rest of the anaplastic features, CDKN2A loss. حتى حالتنا صورتي أنا بصراحة شايفتها أنا أحلى من هاي الصورة من صورتهم بال WHO. إيش صار؟ طيب. It's considered to be around grade 3 زي الانابلاستيك astrocytoma علشان هيك it's important for the like this is not GBM but this is not pilocytic astrocytoma so we have to be careful. بتفرق كتير مع المريض for the management as well as for the counseling. And I think this is the last slide. Thank you very much. خلص كيفني معاكي؟
That's wonderful. Thank you very much for keeping up with the time, even less than you should have taken it. Thank you very much, Maisa. As always, very informative and to the point. Really, we're so proud. We have really an Arab pathologist, one like Dr. Maisa al-Husseini. So would you give her another hand?
Thank you very much. So بس شغلة واحدة بدي أحكيها دكتورة
By
إيمان.
the way, I have to say something, please. No, in favor of you. By the way, she is the first female to be the secretary of the International Academy of Pathology Arab Division. So another big hand for her.
Thank you very much. شكرا جزيلا دكتورة. شكرا دكتورة سلوى. So the algorithm that I made for CNS tumors for methylation, all pediatric medulloblastomas, now the subgrouping is through the gold standard is methylation. لأنه حتى صارت مش بس الفور molecular subgroups, the subgroups of the subgroups صاروا important. There are clinical trials on the stratification. So it is medulloblastoma. كل البيدياتريكس diffuse low grade glioma. كل البيدياتريك diffuse high grade gliomas. البيشنتس adult patients اللي هم من عمر young adults اللي هم من عمر 18 ل 39 سنة اللي عندهم glioma and it's IDH negative by immunostain, you have to do methylation. You'll be surprised by التشخيص اللي بتطلع. Patients older than 55 years of age by immunohistochemistry IDH wild type don't bother even ولا بتغير التشخيص بتضلها GBM wild type IDH wild type. Meningiomas اللي عليهم حكي كتير nowadays male meningiomas have to be methylated. أي شيء that is atypical meningioma, anaplastic meningioma أو grade 1 meningioma على الحفة يعني 3 mitosis بدل 4 you have to methylate لأنه it changes really the grading of the tumor. Brain invasive meningiomas you know no longer are grade 2 هلأ صار اسمهم brain invasive otherwise benign meningiomas. This depends on the molecular classification. Female بالثلاثينات بالأربعينات عندها classical meningioma do not even bother to methylate. So في بصراحة من تجربة الميثيليشن مهم كتير بالبيدياتريكس مهم بcertain groups بالمننجيومز وبالolder adults don't يعني بالGBM ولا تعمل methylation. It doesn't add any value.
Okay, the pineal tumors بتبعتوهم كلهم لأنها usually very small biopsy ولا بكل الباينيال؟
بزبط yes بنزيد الcuts عشان to increase the content of the DNA.
Okay, thank you.
Okay, thank you, Dr. Maisa. Our next speaker is Professor Iyas Hattab. I believe Professor Iyas was introduced in the earlier session, but I have to say that we are very proud to have internationally recognized neuropathologists like Dr. Iyas and Dr. Maisa. ده الحقيقة فخر لينا إن يبقى في ناس زيهم عرب نقدر نتواصل معاهم بيساعدونا كتير. Dr. Iyas is going to talk to us about his talk is titled Algorithmic and Managerial Approaches to the Diagnosis of Adult Gliomas, and he will be joining us virtually.
ومساء الخير. I want to thank you for the opportunity to be with you again today and for being part of the annual International Ain Shams Medical Congress. I would like to begin by thanking Dr. Manal al-Mahdi and the Congress organizers for the invitation and the privilege of joining you today. Over the next 45 minutes, I will discuss algorithmic and managerial approaches to the diagnosis of adult gliomas, with particular emphasis on how modern WHO classification principles can be applied in a practical, structured, and clinically meaningful manner. To illustrate these concepts, we will work through a few examples, time permitting. The objectives of today's talk are to introduce managerial classification, review key advances in CNS tumor classification, and demonstrate how a stepwise algorithmic approach using morphology, IHC, and surrogate markers can support accurate glioma diagnosis across different practice settings. At its core, the goal of any diagnostic exercise is proper categorization, going as far as the available information allows, but not beyond it. As pathologists, our responsibility is not to overinterpret or force a diagnosis, but to provide the most accurate and defensible classification supported by the data at hand. When I refer to a diagnostic algorithm, I mean a structured, step-by-step decision-making process that guides how we gather information, select tests, interpret results, and arrive at a diagnosis. This process begins well before the microscope, with clinical presentation, imaging, and other contextual data, and continues through morphology, immunohistochemistry, and when appropriate, molecular testing. This brings me to the concept of managerial classification, which is central to today's discussion. Managerial classification is not a new idea. Pathologists have long grouped tumors in ways that guide clinical management. This is something that the father of modern surgical pathology, Bernie Ackerman, who you can see sitting in the center of this photo, and his fellows or disciples continued to emphasize. I was fortunate to train with three of his fellows, Dick Kempson, as well as Dorfman at Stanford, and then later Pepper Daynor at Washington University. What has changed in managerial classification is the complexity of the data and the need to translate that same mindset into the molecular era. The concept itself hasn't. Managerial classification refers to the grouping of tumors based on shared pathologic features in a way that informs additional workup and ultimately clinical management and treatment decisions. In practice, meaningful classification means grouping tumors in a logarithmic, hierarchical fashion, starting broad, then narrowing as supporting data becomes available. Importantly, this approach goes as far as the data allow, but does not force a genetically defined diagnosis when the required molecular information is absent. In such cases, a broader but accurate category is the most responsible diagnosis. This raises an important challenge. How do we apply an algorithmic managerial classification approach in the setting of modern neuropathology, where light microscopy alone is often insufficient and subject to high inter-observer variability? Modern neuropathology is defined by the ability to integrate clinical, radiologic, histologic, immunohistochemical, and molecular data into an accurate and reproducible diagnosis, what we refer to as an integrated diagnosis. Importantly, modern practice does not always mean complex molecular testing. Meaningful integration can often be achieved using pragmatic and widely available tools. The real question then is, how do we adapt this integrated algorithmic approach in settings where access to molecular testing may be limited? This is where thoughtful use of morphology, immunohistochemistry, and surrogate markers becomes essential, and where managerial classification proves particularly valuable. Two major paradigm shifts occurred with the 2000 WHO update. First, tumor entities became increasingly genetically defined. Second, the concept of integrated diagnosis was formally introduced. The C-Impact Now consortium served as a bridge between 2016 and CNS-5, helping translate rapidly evolving molecular discoveries into practical diagnostic guidance. With CNS-5 and soon CNS-6, molecular diagnostics take on an even more prominent role, reshaping how we define, grade, and group gliomas. One of the cornerstones of practicing modern neuropathology is the concept of integrated diagnosis. Adherence to the integrated diagnosis format promotes transparency, reproducibility, and clarity, particularly when molecular data are incomplete or still pending. CNS-5 groups gliomas into biologically and clinically meaningful categories. The distinction between adult type and pediatric type diffuse gliomas and between diffuse and circumscribed tumors is fundamental, reflecting major differences in molecular drivers and clinical behavior. These distinctions have direct implications for both diagnosis and management. Once we understand how gliomas are conceptually grouped in CNS-5, the next step is deciding where to enter the algorithm. One of the first decision points in an algorithm approach is growth pattern. Identifying a glioma as circumscribed or diffuse, often based on imaging and histology, directs subsequent diagnostic workup and management. Applying growth pattern to gliomas immediately separates tumors with very different clinical behavior. Circumscribed gliomas are often well-defined and potentially curable with surgery, whereas diffuse gliomas are infiltrative, surgically incurable, and associated with different diagnostic and management considerations. Recognizing this distinction early provides the foundation for everything that follows. Consistent with the principles of managerial classification, if the growth pattern cannot be confidently determined, the most appropriate approach is to retain the diagnosis at the broader level of glioma, rather than forcing further subclassification. Once a glioma is established as diffuse, the next key decision point within the framework is whether we are dealing with an adult type or pediatric type diffuse glioma. CNS-5 treats these as biologically distinct entities with different molecular drivers, clinical behavior, and prognostic implications. In day-to-day practice, we cannot always make this distinction, particularly in borderline age groups or small samples. When that happens, it is entirely appropriate to defer further subclassification rather than introduce diagnostic uncertainty. This slide provides an overview of how CNS5 classifies diffuse gliomas. For the remainder of the talk, I'll focus primarily on adult-type diffuse gliomas. One of the most striking changes introduced with CNS5 is the simplification of adult-type diffuse gliomas. In 2016, this category included numerous morphologic and grading-based entities. In contrast, CNS5 consolidates these into just 3 integrated diagnostic types. This simplification reflects a shift away from pure histologic labels toward diagnoses that are fundamentally grounded in molecular biology, improving reproducibility and clinical relevance. In many respects, the WHO classification has now fully embraced the principles of managerial classification. This simplification also aligns closely with prognostic stratification. Broadly speaking, adult-type diffuse gliomas fall along a continuum from more favorable to more aggressive clinical behavior, largely driven by molecular features such as IDH status, 1p19q codeletion, and key pathway alterations. Importantly, this framework allows us to convey clinically meaningful prognostic information without relying on overly granular or unsupported subclassification. In other ways, this reflects a fundamental transition in CNS5 from categorization based on morphology to one driven by biologic behavior. That shift fundamentally strengthens the classification. Once we've established the appropriate diagnostic category, the next major decision point is grading. Grade reflects biologic aggressiveness and provides important prognostic information, but within the CNS5 framework, grading is applied within defined tumor types rather than used to create separate entities like the previous edition did. This reinforces the shift away from morphology-driven labels toward an integrated approach that prioritizes biology. That said, from a managerial classification standpoint, when immunohistochemical and molecular data are limited or unavailable, the distinction between low-grade and high-grade diffuse glioma remains a highly meaningful and clinically useful level of categorization. A perfect example of that is in the intraoperative setting, where we do not have the additional information. In 2022, the College of American Pathologists charged a group of us with developing a molecular biomarker testing algorithm for diffuse gliomas. The resulting framework highlights just how complex modern glioma classification has become and why a structured algorithmic approach is not optional but necessary. With that, let's go over an immunohistochemistry guided diagnostic algorithm for adult type diffuse glioma. The intent here is not to memorize the pathway, but to demonstrate how a limited, well-chosen set of immunohistochemical markers, used in the right sequence, can reliably guide classification and triage for additional testing. This approach allows us to move stepwise from a broad diagnosis of diffuse glioma toward more specific categories, while remaining aligned with the principles of managerial classification. So let's begin experimenting with this algorithm. So let's say we have a diffuse glioma case. It's in an adult. Our first layer of immunohistochemistry preferably is OLIG2. But if you only have GFAP, that's fine. The goal here is to make sure that this is a glial neoplasm. Next, we layer up IDH1 R132H immunohistochemistry. Pair this algorithm. If it's mutant, then the tumor will be positive, provided it has this subtype of the mutation. Then we add ATRX and P53. And ideally, if you have the luxury of having Vimentin and H3K27 ME3, it's advisable to add those. These are particularly helpful if you have retained ATRX and P53. If you have loss of one or the other, technically you can skip them. So let's say that you do have retained ATRX and P53, you applied Vimentin and H3K27ME3 and had a negative Vimentin and preferably loss of H3K27ME loss. That's when this is an indirect evidence of oligodendroglioma, and you can suggest that diagnosis if you do not have 1p19q co-deletion. Now, let's assume that Vimentin is positive and H3K27ME3 is retained. In that case, you're unlikely to have the 1p19q co-deletion, and absent that, you are likely dealing with an IDH mutant astrocytoma. Let's go back to our IDH mutant tumor that shows either ATRX loss or P53 overexpression, or rarely, perhaps completely negative or null pattern. The presence of any of those, ATRX loss, P53 overexpression, or complete lack of expression in the setting of IDH mutation is evidence of an IDH mutant astrocytoma. Why? Because ATRX is an astrocytic marker, same for P53. Now, if IDH1 R132H is negative, then we move on to the other side of the algorithm. We would still perform ATRX, P53, Vimentin, and H3K27ME3, preferably as a panel. If you have ATRX loss in a scenario where IDH1 is negative, then that's an indirect evidence that we do have a non-canonical IDH mutation, one that the immunostain can detect. And this is where redundancy of immunostains is very helpful. And if you have good immunohistochemistry, that is ground for calling the tumor IDH mutant astrocytoma. If you are dealing with a adult type diffuse glioma. Now let's assume that the same tumor has p53 overexpression or lack of expression, with or without ATRX, but ideally with ATRX loss, then again, that is evidence of IDH mutant astrocytoma. Now, if ATRX is retained or p53 is not overexpressed, then this is evidence of diffuse glioma IDH wild type, not otherwise specified. There are exceptions to this combination of or pattern of immunostain, and the exception is if we are dealing with an oligodendric glioma that has a non-canonical IDH mutation, then it will be, the IDH1 will be negative, the ATRX will be retained, p53 will not be overexpressed. However, Vimentin is likely to be negative and H3K27Me is likely to be lost. And that would be kind of your way of recognizing that this is indeed not an IDH wild type glioma, but perhaps an oligodendric glioma. That is an important distinction in this case. Now, let's go back to the diffuse glioma IDH wild type, not otherwise classified. If we have GBM histology or the patient is over 55 years of age, then it is safe to call this glioblastoma IDH wild type WHO grade 4. However, if the patient is not over 55 years of age, or we do not have GBM histology, then we do need to do molecular testing, or if we do not have available molecular testing to designate this tumor as diffuse glioma IDH wild type, not otherwise specified. If we take inventory of the various diagnostic outcomes produced by this IHC-guided algorithm, we arrived at these combinations in these boxes. What this illustrates is just how much actionable diagnostic information can be extracted without the need for exhaustive molecular testing. This is essentially what you can do just with 4 or 5 immunohistochemical stains. So with that, let's go through a few case examples. I have 5, so hopefully we'll be able to go through them. So the first one is a 30-year-old man with recent history of thoracic myxoid sarcoma, presented with altered mental status. And an MRI showed this frontal 2T hyperintense non-contrast enhancing mass, and the patient underwent craniotomy and resection. Histologically, you can see that this tumor has an infiltrative pattern on the left-hand side, and if we move to higher power, it has a prominent microcystic pattern. There doesn't seem to be vascular proliferation. It does have focal increase in cellularity. We can even see some evidence of hemosiderin-laden. Moving on to higher power images. On the left-hand side, we can see a moderately cellular glial tumor, still delicate blood vessels. In the middle, we do see evidence of nuclear pleomorphism. And in the right-hand side image, we do see scattered mitoses. Looking at the pattern of immunohistochemistry, this tumor shows OLIG2 immunoreactivity, It's negative for IDH1. If you look closely on ATRX, I hope you can see that the endothelial cells are staining well, providing positive internal control, but the tumor cells are negative, meaning there is loss of ATRX nuclear expression. This is an indirect evidence, as all of you know, of an ATRX mutation, but it's also an indirect evidence of a non-canonical IDH mitosis. Looking at the pattern of immunohistochemistry, this tumor shows olig 2 immunoreactivity. It's negative for IDH1. If you look closely on ATRX, I hope you can see that the endothelial cells are staining well, providing positive internal control, but the tumor cells are negative, meaning there is loss of ATRX nuclear expression. This is an indirect evidence, as all of you know, of an ATRX mutation, but it's also an indirect evidence of a non-canonical IDH mutation in this example. P53 is not overexpressed, shows just scattered nuclei, and MIB1 is shows a smattering of nuclei. So what's your diagnosis and what additional studies would you like? So I'll pause for a moment and then. Now I want to emphasize the point of ATRX serving as a surrogate marker for an astrocytic mutation in the setting of adult type diffuse gliomas, but also indirectly serving as a surrogate marker for non-canonical IDH mutations. That's really important for us to recognize because it allows us to better manage these cases and for us to understand hopefully the relationship within adult type diffuse gliomas of these molecular markers. So as you know, IDH mutant group is the group that harbors potentially ATRX mutant or 1p19q co-deleted tumors. Luckily, there are no IDH wild type adult type diffuse gliomas that show ATRX mutation or 1p19q co-deletion. So this is when knowing the relationship between these markers allows us to make the diagnosis, the correct diagnosis in this case. So let's go over a summary of this case. So this is a 30-year-old, so that's typically an adult. It would be unlikely to have a pediatric type tumor in this age. Per morphology, we demonstrated that this was glial. It did have a diffuse or infiltrative growth pattern. We determined the grade through the presence of pleomorphism, increased mitotic activity, focal increase in cellularity, and then we determined the presence of an first ATRX mutation because of the ATRX loss of expression, and indirectly the presence of an uncanonical IDH mutation, and that's where we called it IDH mutant astrocytoma. So how did we get there? If we go back to our algorithm, we got there through an IDH1 negative pathway, but luckily a loss of ATRX expression that led us back to the IDH mutant astrocytoma diagnosis. So our diagnosis in an resource-limited setting would be astrocytoma IDH mutant WHO grade 3. If you are in a resource-intense setting, ideally you would want to sequence this tumor to confirm the presence of an IDH. And in this case, the patient did have an IDH1 R132C mutation detected through sequencing. And with that, our final integrated diagnosis is astrocytoma IDH1 R132C mutant WHO grade 3. Obviously, if we don't know the exact mutation in a resource-limited setting, you can just say IDH mutant WHO grade 3. Say C note and explain how you arrived at that diagnosis. So this case would not be complete without addressing some CNS5 recommendations and specifically talking about CDKN2AB homozygous deletion. So a few years ago, we were shown evidence that the presence of CDKN2AB homozygous deletion in IDH mutant astrocytomas and later in IDH mutant oligodendrogliomas or oligodendrogliomas, since all of them are mutant, does affect survival. And what those studies showed is that essentially, regardless of grade, that the presence of these alterations were prognostically poor. And for that, the CNS5 suggested adding or really added CDKN2AB homozygous deletion as a molecular feature of WHO grade 4 IDH mutant astrocytoma. Now, fast forward after the publication of CNS5, we've had an opportunity to learn more about CDKN2AB homozygous deletion. And what we've learned is that, unfortunately, most of these studies did not use the same methodology, or cutoffs. And so that really created a difficulty in trying to make sense of that data, and that's why there was variability in the outcome. We also have since learned that, well, if we take grade 2 or grade 3 IDH mutant astrocytomas, that the incidence of having CDKN2AB homozygous deletion is really low. We're talking about 2 to 3% in grade 2 and 3 to 7% in grade 3, meaning that the percentage of having those alterations is really small, and they may not be as impactful as originally thought. With oligodendrogliomas, if you're dealing with a grade 3, they tend to be slightly higher, up to 10%. So this begs the question, is testing for CDKN2AB homozygous deletion necessary in resource-limited setting? And this is a conversation I think you would want to have in your local institution and with your oncologists. But if you don't test a case that is a lower grade IDH mutant astrocytoma, you at least want to include that in the comment and address that this was not performed. However, the incidence of these remain fairly small. So let's move on to case 2. Here is a 47-year-old woman 4-month history of seizures and vision changes. And as you can see, the MRI revealed a lesion in the left hippocampus and parahippocampus gyrus. The patient underwent a stereotactic biopsy. As you can see with this stereotactic biopsy, there is still evidence of a gradual increase in cellularity, so it does have this infiltrative growth pattern. The tumor cells and the nuclei on higher power are hyperchromatic, and there are apoptotic figures. The IDH mutant in this case was negative. ATRX was retained. P53 was about 10 to 15%, so really can't call it, at least in my dictionary, overexpressed. I realize the WHO had a 10% cutoff. One important takeaway here is that if it's not really overwhelmingly positive, approaching 50%, the usefulness of P53 remains doubtful. And MIB1 was slightly elevated in this case. So, what's your diagnosis? If we go to our algorithm, this is was an IDH1 negative case. ATRX was retained, and so was P53. We called it, at least here, indeterminate or unambiguous. In the presence of retained ATRX, this is the diffuse glioma IDH wild type, not otherwise specified. Do we have GBM histology? No. Is the patient over 55 years of age? No, the patient is only 47. So technically, we would require molecular testing in this case. Now, if we do not have molecular testing, we would call this diffuse glioma IDH wild type, not otherwise specified. So in a resource-limited setting, that would be our diagnosis. But if we are in a resource-intense setting, then this is a case you do want to sequence to confirm the absence of IDH mutation and to look for TERT, EGFR alterations or copy number abnormalities. So why is that? Why would we want to do that? As we explained, in patients who are younger than 55 years of age, the incidence of IDH mutations is higher. And then the CNS5 illustrated to us that we do have molecular features of GBM that we should entertain when dealing with adult-type diffuse gliomas. And those are, as described, the TERT mutation, EGFR amplification, and copy number abnormalities. This case did show genomic abnormalities in EGFR and was diagnosed as glioblastoma IDH wild type, WHO grade 4. So what's new in molecular GBM? Well, what we've learned in the past few years since CNS5 is that, yes, these tumors do behave worse than your typical grade 2 or 3 gliomas. However, they do not behave as poorly as histologic glioblastomas. So the question here is, should they be treated the same? Should we even use the same terminology? Should we preserve the older terminology of molecular features of GBM? We've later learned through more recent studies that if you have TERT promoter mutation alone, that those tumors may not behave as aggressively as previously thought. Meaning, if you only had TERT mutation but no EGFR alterations or copy number abnormalities, meaning in isolation, then this may not represent a molecular GBM. And so with the C-Impact now 11 update, there's been a revised diagnostic criteria for GBM IDH wild type. And if you notice, under essential criteria, the next to TERT, EGFR, and copy number abnormalities, there is this qualification that says not as solitary defining factor in histologically low-grade tumors or younger than 40 years of age. So the take-home message now, if you have only isolated alteration, whether it's TERT, EGFR, or copy number abnormalities in 7 and 10, then exercise caution. Do not call this flat-out molecular GBM, or call it and put a note to that effect. And that's what is summarized in this slide here. So let's move quickly to case 3. This is a 34-year-old woman with a frontal lesion that is non-contrast enhancing. A resection showed a diffuse growth pattern, some microcyst formation, secondary structures of Schur, and the tumor was IDH1 negative, ATRX was retained, and there was no overexpression of P53. There was some scattered mitosis, but H3K27ME was lost, and there was nice internal control. Vimentin was largely negative. If you can see, it's really mostly showing staining around blood vessels, and then MEB1 was slightly elevated. So, what's your diagnosis, and would you require any additional studies? Well, in a resource-limited setting, this would be an example of diffuse glioma, not otherwise specified. However, with features consistent with an oligodendroglioma, IDH mutant, and 1p19q co-deleted. Why is that? That's because the tumor showed the H3K27ME 3 loss and absence of Vimentin. If you go back to our algorithm, that's what this suggests. Now, obviously, if you have access to molecular diagnostics, or at least FISH, 1p19q co-deletion would be important in this case, and we were able to confirm it in this patient, as well as the presence of an IDH2 mutation. Following the algorithm, this is what the caveat I mentioned earlier, is that this is the one case we do not want to call IDH wild type diffuse glioma. As you can imagine, this is a significant difference in behavior between an oligodendroglioma and an IDH wild type. So please be careful of those nuances. Case 4 is a 35-year-old man, had a mixed signal intensity frontal mass, and then underwent craniotomy and resection. The tumor was cellular. It did have a diffuse growth pattern. There was apoptosis, pleomorphism, and looked higher grade. With immunohistochemistry, IDH1 was negative. However, there was ATRX loss of expression with positive internal control, as you can see. And P53 here in this case shows absolutely no staining. And this is a good example of a null pattern. The MIB1 was not expressed. So what's your diagnosis, and do you require any additional studies? Well, going back to our algorithm, this is an example of both ATRX loss and P53 overexpression in the absence of IDH1 R132 expression. So this is an IDH mutant astrocytoma. And this is really an acceptable diagnosis, essentially whether you're in dealing with a resource-limited setting or perhaps a resource-intense, although I can tell you in our practice, we would still sequence this for confirmation. And this case was sequenced and showed the presence of an IDH mutation. I realize I am right at 45, but I'll go do this case quickly and wrap up. So 21-year-old severe headache, underwent craniotomy and resection. You can see that on low power, there is a low to moderately cellular tumor, appears to have infiltrative pattern with cytology. The cells appear somewhat rounded, but the blood vessels are thin and branching. There is quite a bit of nuclear polymorphism and scattered apoptosis and mitotic bodies. With immunohistochemistry, IDH1 is strongly positive. There is loss of ATRX expression. There is a bit of background, but it is a cytoplasmic background, so it doesn't matter as much in the presence of good internal control. And clearly, the P53 is at least 50%, so it is overexpressed. So what's our diagnosis, and do we need any additional studies? So back to our algorithm, this is kind of a straightforward example again of IDH mutant astrocytoma by virtue of both the presence of the IDH R132 immunostaining, the ATRX loss of expression. So really, again, this is a scenario where we do not need any additional studies. Perhaps, you know, the one thing you could consider is CDKN2A homozygous deletion, and in this case, it was not detected. So those were all the cases I have. My takeaways quickly here is that the algorithmic managerial classification provides a disciplined framework for modern glioma diagnosis, that despite the complexity of today's CNS tumor classification, a significant number of genetically defined entities, as we've just demonstrated, can be adequately identified using existing surrogate markers. The presence of these surrogate markers is what really facilitates this workup. And then diagnostic restraint is essential when we do not have all the information we need. So just remember, do not force a diagnosis where it may not belong. And at the end, just remember that even with all the tools we have, there's no one method that is capable of fully characterizing CNS tumors. And at the end, a variety of approaches is what's really needed. I thank you for your attention and look forward to being back with you soon. Thank you.
Yes, I'm here. Can you hear me?
Where are you? Ana Salwa.
Yeah, hi Salwa. Can you hear me okay?
Hello, dear. Hi.
Sorry, you know, I'm in a construction zone, so here it's a bit, it can be a bit loud, but really glad to at least see some of you live. I'm disappointed I'm not with you in person.
Not few of us, all of us are disappointed because you're not here, of course.
Yeah.
But
Unfortunately, I was going, you know,
Maisa
I had
is
my
covering a
ticket.
little bit of your absence, okay? But still, we need to see you. But sure, we are going to see you. I'm going to see you in 4 weeks' time, inshallah.
I look forward to it.
Yeah,
Absolutely.
inshallah. Thank you very much for your presentation. As usual, it is very informative. And thank you very much. And I think, should we open for discussion? If anybody wants to ask you anything, would you like to accept something like this? If anybody wants to ask us, are you ready to answer the questions? Are you ready or not ready?
I'm happy to.
Can you hear me?
Sure.
Okay, fine. Anybody wants to ask a question to? Okay, Iman will ask you a question.
Hello, Dr. Yes, Iman عبد الظاهر.
أهلا دكتورة إيمان.
أهلا. عندي سؤال على ال H3K27 dimethylation.
Right.
When I say it's lost, should it be lost in all tumor cells and retained in the internal control, or there is a percentage?
Yeah, you bring up an excellent point, and I can tell you this is a very tricky stain to optimize, and there's been quite a bit in the literature. If you look at several studies, have looked at the importance of having a specific dilution of H3K27 ME3. And so, meaning, you know, again, IHC is an LDT, right? It's a laboratory developed test, and we optimize the antibodies in-house. And so the goal is to optimize it to work specifically for cases that are co-deleted. And so this is when we optimized our antibody, we actually got a set of 1p19q co-deleted and a set of 1p19q intact gliomas, and made sure that we validated it for that purpose. If you randomly take an H3K27 ME3 and off shelf and have it slightly higher antibody concentration, it will show you a pattern that's either completely retained, or it'll show you what you're describing, which is difficult to interpret, which shows some areas that are intact and others that are lost. So my takeaway point is go back to the literature. I'm happy to provide you with our dilution to give you the exact dilution that we use here. But you will need to, first of all, tweak or optimize the antibody on a 1p19q co-deleted set to make sure that this is actually going to work appropriately. So again, to answer your question is, if it's not entirely and completely lost, I would be cautious about using it as a surrogate marker.
Thank you very much. Another question. The WHO and the CAB mentioned that below 55 years, do the sequencing. Above the 55 years, it's not necessary, but they do not mention people that are 55 years exactly. There's no equal.
Yeah,
no equal
yeah.
sign.
I mean, yeah. You know, the literature, you're correct. I mean, the literature says if it's equal or more, you know, basically you don't have to do it. In all honesty, I feel like this may be a bit overstated. That in our practice, we still sequence people who are under 60 years of age. Why do we do that? Because we have the luxury to do it. But I can tell you that just last week, Dr. Ayman, I saw a 68-year-old with an IDH mutation, okay? So it does happen, you know, it's just that the incidence after age 50 in general goes significantly lower. But I would say, you know, if I have a 55-year-old, I'm doing sequencing on it just because they still have a decent chance of having an IDH mutation.
Thank you so much.
Of course.
Anybody? Okay, thank you very much, yes, and hope to see you soon in Egypt.
Absolutely, I would love to, and have fun. Enjoy the rest of your evening, and look forward to seeing many of you soon. Take care.
Thank you. Thank you very much. Bye-bye.
Bye-bye. Bye.
And now we're going to move to the cases, solving the brain puzzle, challenging cases in CNS histopathology. 5 of our brilliant lecturers and assistant lecturers from Ain Shams University are going to provide us with 5 interesting cases under the supervision of Professor Dr. Manal Al-Mahdi, the head of the department. And we're going to start with case number 1, Dr. Nisma Mansour, a lecturer of pathology at Ain Shams University.
Good evening. I would like to first start by thanking Professor Dr. Manal Al-Mahdi and Professor Dr. Nihal for including us in this presentation, and extend my greetings to the esteemed chairpersons and professors attending. This case is under the supervision of Professor Dr. Manal Al-Mahdi. A 21-year-old female presented with a left frontal space occupying lesion, complaining of bouts of confusion, urinary incontinence, vomiting not preceded by nausea, social disinhibition, and no history of fits. T2 image showing a predominantly left hemispheric lesion with mass effect and surrounded by vasogenic edema. Also seen here a true diffusion restriction with extension of the mass to the right, to the contralateral right side via corpus callosum, and post-contrast heterogeneous enhancement. Grossly, we have received the current specimen as fragments, as seen here on the low power, where we can see a neoplastic growth admixed with hemorrhage in form of a sheeting pattern. A higher power view, we can see hyperchromatic nuclei with scanty cytoplasm and areas of necrosis. So on visiting the history of the patient, this patient underwent right frontal VP shunt on February 2021, followed by posterior fossa space occupying lesion, then had multiple shunt revisions on 2024. The CT scan, non-contrast CT, showing a well-defined hyperdense mass on the posterior fossa with signs of obstructive hydrocephalus. Grossly, we received the posterior fossa space occupying lesion as fragments that were submitted into blocks. We can see a neoplastic growth admixed with hemorrhage. Higher power show the undifferentiated small round blue cells and attempts of rosette formations. Immunohistochemical staining was done, showing a beta-catenin no nuclear staining with cytoplasmic staining. P53 showed weak scattered positivity, negative for YAP1, and also negative staining for immunohistochemical staining by GAP1. Also, CSF cytology was submitted, showing CSF seeding by the neoplastic cells. So the diagnosis of the posterior fossa space occupying lesion is classic medulloblastoma, non-Wnt, non-sonic hedgehog, P53 wild, CNS WHO grade 4. In continuation of the patient history, the patient received chemotherapy and radiotherapy, latest on 2023. So today's left frontal space occupying lesion, the neurosurgeon's provisional diagnosis was radiation-induced glioma. So we're a little bit confused on the timeline now. So let's revisit the chronological order. On 2021, the patient received a right frontal VP shunt, then a posterior fossa space occupying lesion excision on 2021, followed by chemotherapy and radiotherapy, latest on 2023, multiple shunt revisions on 2024, and then today's current lesion of left frontal space occupying lesion with right side extension as a butterfly lesion. Let's recall the microscopic picture of the frontal space occupying lesion we mentioned at the beginning. Immunohistochemical staining of GFAP was negative, as well as the LCA, and we seen a focal positive staining of synaptophysin. So the diagnosis is metastatic medulloblastoma CNS WHO grade 4. A quick take on the metastasis in medulloblastoma. Of course, we need to consider the molecular subtyping, where Wnt group is really metastasizing at 10%, sonic hedgehog at 15 to 20, group 3, which carries the poorest outcome at more than 55% to distant metastasis, and group 4 at 40%. And the spread is through CSF or hematologenous route. 40% of the classic medulloblastoma has disseminated leptomeningeal disease. Extraneural carry approximately 5%. And I want to highlight that an isolated local recurrence of group 3 or group 4 medulloblastoma should be considered as a radiation-induced neoplasm until proven otherwise. Given the patient age, the medulloblastoma occurrence in the adolescents and young adult population decreased dramatically to 0.05 to 0.1 per each 100,000 cases, where the metastatic disease is one of the critical prognostic factors, where it's slightly higher than the pediatric population at 25 to 35% with unfavorable. Also, 5 to 7% of the medulloblastoma cases get secondary neoplasms like glioma, which is thought to be irradiation-induced. A quick look at multiple case reports that discuss rare incidents of supratentorial metastasis here at the parietal lobe, where we can see the contrast MRI and the desmoplastic nodular medulloblastoma histopathological examination. Another case for metastasis in the right temporoparietal region, where the CT scan showing the mass. And the last case we have is for a medulloblastoma case with supratentorial metastasis. All these three cases had in common the metastasis that occurred 2 to 5 years after the therapy. With that, I conclude my session, and thank you so much.
Thank you very much, Dr. Nesma. Now with Dr. Fatma Al-Garhi, lecturer of pathology at Ain Shams University.
Good evening. I'm Fatma Gendi, assistant lecturer of pathology at Ain Shams University. Now I will be presenting case number 2 under supervision of Professor Dr. Manal Al-Mahdi. Our case is a 13-year-old female patient presented with progressive attacks of seizures with unremarkable medical and clinical history. MRI was done for her, and it revealed occipitoparietal temporal cortical based space occupying lesion, as we can see here. And here also. Biopsy was done, and it was described by the surgeon as a soft saccable grayish white space occupying lesion received in our lab as multiple fragments. By examining the low power of the slide, we can appreciate that it's somehow fairly defined with multiple nodules. When we examine the higher power, we can notice that the tumor is formed of neoplastic cells, somehow with bland nuclei and uniform, and the background is myxoid stroma. Another field showing that these monotonous cells are arranged in columns with the entrapped neurons in between and the myxoid background. By the higher power, we can notice the nuclear features. All the cells showed almost bland, uniform-looking nuclei with no mitotic activity, and we can see the scattered neuronal cells. Again, higher power, where we can appreciate the entrapped neuronal fibers and stromal myxoid content. So we are facing a low-grade neoplasm with bland cytology and low-grade neoplasm with bland cytology and low mitotic index. All the cells are having uniform small round nuclei with clear surrounding cytoplasm, with scattered entrapped neuronal cells and myxoid background. So isn't these cells oligo-like? Yes, they are. So our differential included the oligo-like morphology tumors. including oligodendroglioma with immunopositivity for GFAP, OLIC2 and IDH, and the characteristic 1b19q co-deletion and negative synapto and EMA staining. Second differential was diffuse astrocytoma MIB and MIB-L1 altered with positive GFAP and OLIC2 and negative IDH synapto and EMA. DNET, which shows a positive synapto in the neuronal element and a positive OLIC2 and S100 with negative EMA, GFAP, and IDH. Plenty, which is a strongly positive for CD34 and GFAP and negative for IDH and EMA. Central neurocytoma, which showed a strong diffuse positivity for synapto, negative staining for IDH, GFAP, EMA, and OLIC2. And ganglioglioma, which is characterized by BRAF V600E alteration, positive GFAP staining, positive synapto, and sometimes positive for CD34 with negative EMA and IDH. Pilocytic astrocytoma, which is positive for GFAP, OLIC2, and negative for synapto, EMA, and IDH. And lastly, clear cell ependymoma, which shows the characteristic dot-like positivity of EMA and negative synapto and OLIC2. So let's start to narrow the differential using the immunohistochemistry. This was our applied panel. Let's start with the negatives. Our case was negative for EMA, which excludes the clear cell ependymoma. Negative for IDH1, which excludes the oligodendroglioma. And negative for CD34, which exclude plenty and makes ganglioglioma less likely. Synaptophysin staining was applied and showed positive staining only in the floating neuronal and no staining in the tumor cells. This excludes the central neurocytoma. Regarding the oligo-like cells immunohistochemistry, they showed positive staining for both OLIC2 and S100, as we can see here, and negative staining for GFAP. So now we can exclude the diffuse astrocytoma, pilocytic astrocytoma, and we are left with the diagnosis of our case, which is DNET. So the case was signed out as a case of dysembryoblastic neuroepithelial tumor, WHO grade 1. Ki-67 in this case was low, with proliferation index of 1%. And we also added Alshan blue staining, which showed positive extracellular staining in the myxoid matrix in the background. DNET is somehow a rare CNS tumor with incidence of 0.5 to 1% of all primary CNS tumors and around 5.9 of epilepsy surgery cases. It classically presents with intractable seizures. It's located in the cerebral cortex, mainly in the temporal loop, followed by frontal loop. Regarding molecular, it usually shows germline mutation in MABK pathway genes, including FGFR1, NF1, and BTBN11. Prognosis of these cases is usually benign with low rate of recurrence after resection, with rare case reports of malignant transformation. So let's sum up the characteristic microscopic features of this case. It showed multinodular intracortical growth pattern with oligodendroglioma-like cells and floating neurons in myosin pools, with no dysplastic ganglion cells, no increased mitotic activity, high cellularity, necrosis, significant perivascular lymphocytic infiltrate, or EGBs. And its immunophenotyping panel showed positive staining for synaptophysin in the neurons, for S100 and OLIC2 in the oligo-like cells, negative staining of GFAP in the oligo-like cells, with negative staining of CD34, IDH1, and EMA, low proliferation index using Ki-67, and extracellular positive staining using special stain of Alshan blue. Thank you.
Case number 3 is going to be presented by Dr. Yasmin Salah, a lecturer of pathology at Ain Shams University. Dr. Yasmin has got experience abroad in China for, I think, around a year. So she's going to present the 3rd case.
Good evening, everyone. Thank you for having me. I will be discussing case number 3 in our neuropathology workshop. I am Dr. Yasmin Ahmad Salah, Assistant Lecturer of Anatomic Pathology. First and foremost, I would like to pay sincere gratitude to our mentor, Professor Dr. Manal Mahdi, Professor of Anatomic Pathology and Head of Anatomic Pathology Department. So our case is a case of dorsal mass lesion occupying the right hemisthorax, extending at the level of D3 up to D6. She's a 14-year-old female who is medically free and surgically free. She came to the ER complaining of bilateral lower limb weakness and numbness of 5 days duration. She had no previous neoadjuvant therapy, and she was provisionally diagnosed by lymphoma versus sarcoma. Her radiology showed a paraspinal mass occupying the space between T3 and T6. It had an intradural with extramedullary extension, compressing the spinal cord. The gross examination of her specimen showed multiple rubbery grayish tan tissue pieces, measured collectively 1.5 by 1.5 centimeters, that was multisected and totally submitted. The microscopic examination of her slides showed, using low power field, a highly cellular neoplasm with vague areas of necrosis. The higher power field showed a small round blue cell tumor with fine chromatin and intersecting fascicles of hyalinosis and fibrosis, with some adjacent foci of hemorrhage, and some areas of rosetting. Some fields showed apoptotic cells as well. So the differential diagnosis for this case included lymphoma, for which we use the markers LCA, TDT, Ewing sarcoma, for which we use CD99, NKX2.2, also included metastasis of small round blue cell tumors such as neuroblastoma, and for this we use the NMIC amplification test. It also included small cell osteosarcoma, for which we use SADB2, and desmoplastic small round cell tumor, for which we use WT1. We performed a preliminary immunohistochemical panel. We performed CD99 that showed positive staining. High power of CD99 showed diffuse membranous staining. We also performed NKX2.2. Low power field showed positive staining. High power field showed diffuse positive nuclear staining of NKX2.2. We also performed LCA to exclude lymphoma. It was negative. We as well performed synaptophysin to exclude neuroblastoma that showed negative staining. So we reached the diagnosis of malignant round cell tumor compatible with Ewing sarcoma, focally necrotizing. The key notes to know about Ewing sarcoma is that it's the second most common malignant bone tumor after osteosarcoma. It nearly represents 80% of patients. Nearly 80% of patients are less than 20 years old. All cases harbor FET-ETS fusions. The presence of metastasis is the main prognostic factor. Majority of mutations are sporadic, and adamantinoma-like variant can occur with nests of basaloid cells. Thank you so much.
Thank you very much, Dr. Yasmin. Now, Dr. Reem Saeed, Lecturer of Pathology, Faculty of Medicine, Ain Shams University.
Good evening, dear professors and colleagues. I'm Reem Saeed, Assistant Lecturer of Anatomical Pathology in Shams University. This case is under supervision of Professor Manal Al-Mahdi, Head of Pathology Department at Shams University. Our case is a 34-year-old male patient presented with acute paraparesis and urinary and stool incontinence for 10 days duration. MRI spine was done. MRI shows an infiltrative abnormal signal involving a long segment of multiple contiguous vertebral bodies in the cervicothoracic region. There is an associated posterior epidural soft tissue component extending over multiple levels located at D2 to D5 dorsal spine. The patient underwent D2 to D5 laminectomy with debulking of the space-occupying lesion. Grossly, we received multiple grayish white tissue fragments, 5 by 5 centimeter, measured 5 by 5 centimeter collectively, which were totally submitted. Microscopically, by low power field, we could see infiltration of bone fragments by a tumor with atypical round cells in vaguely nodular architecture. Another field of the same findings. Another field for the bone infiltration. And here the field highlights a sclerotic background. Higher power field demonstrating the atypical round cells with polymorphic nuclei and perinuclear halos. Higher power of the same field, we could appreciate the atypical round cells with the perinuclear halos. The atypical cells are admixed with inflammatory cells. Given the histological picture of small round blue cell tumor in this age group and location, several differential diagnoses were considered, including multiple myeloma, lymphoma, metastatic small cell carcinoma, undifferentiated round cell sarcoma, desmoplastic small round cell tumor, and metastatic small cell carcinoma. Upon further inquiry into the patient's medical history, it was found that the patient had a history of multiple lymphadenopathy. So can you guess the diagnosis based on the patient's history of multiple lymphadenopathy? Let's take a look first at the H&E sections of the lymph node biopsy that was taken. Examination of the lymph node by low power revealed replacement of normal nodal architecture by nodules in a sclerotic background. High power field revealed aggregates of pleomorphic inflammatory cells, including lymphocytes, neutrophils, and eosinophils, with scattered large atypical cells with abundant pale cytoplasm that appears retracting, creating an empty lacunar space around the nucleus. Immunohistochemical panel was done to our dorsal spine space-occupying lesion and compared with that of the lymph node to confirm the final diagnosis that we should all surely guess. CD20, CD3, CD15, and CD30 were performed. CD20 showed scattered positive staining. Scattered positive staining in reactive T cells in both dorsal spine space-occupying lesion and lymph node biopsy. CD3 scattered positive staining in reactive T cells in both biopsies. CD30 scattered positive staining in atypical neoplastic cells in both biopsies. So finally, this is a known case of Hodgkin lymphoma diagnosed 3 years ago, now presenting with spinal involvement. Correlation of the clinical histopathological and immunohistochemical findings confirms the diagnosis of relapsed classical Hodgkin lymphoma, nodular sclerosis subtype. Relapse in Hodgkin lymphoma may present in unusual extranodal sites. Spinal epidural involvement, especially in the dorsal region, is considered a rare manifestation of relapse. A similar case was reported by Pathology et al. In the Journal of Orthopedic Case Reports 2023, describing spinal cord compression due to relapsed Hodgkin lymphoma presenting with neurological deficits. According to Greig et al., spinal cord compression in Hodgkin lymphoma is quite rare, occurs in approximately 2.2% of cases at time of initial Hodgkin lymphoma diagnosis. Thank you.
Thank you. The last case will be presented by Dr. Malak Samir. She is a teaching assistant of pathology at Ain Shams University. Samer, Malak Samer.
Good evening, my dear professors and colleagues. My name is Malak Samer Ahmed, and I'm a teaching assistant of anatomical pathology at the Faculty of Medicine, Ain Shams University. And today I will be presenting case number 5 under supervision of Professor Dr. Manal Al-Mahdi, Professor of Anatomical Pathology and Head of Anatomical Pathology Department, Faculty of Medicine, Ain Shams University. Our case is of a 12-year-old male patient. Came with the complaint of a left scalp swelling of 1 month duration. His history of present illness, it was accidental discovery of a left posterior parietal swelling 1 month ago. It was tender on touch and stationary in size. On examination, the swelling was a left posterior parietal globular swelling, 3 centimeters in diameter, tender, intense, with a cystic consistency. It was well demarcated and immobile, covered by scalp with a normal hair pattern. The provisional diagnosis of the surgeons was an epidermoid cyst. The picture on the left shows a well-demarcated scalp lesion covered by hair, and on the right, this is a diagram showing the cut section of an epidermoid cyst containing yellowish material. And so now the question is if this lesion is truly an epidermoid cyst. The patient underwent MRI of the brain, and these were the MRI findings: a left high frontal, well-circumscribed expansile oval-shaped mass measuring 1.7 times 1 centimeter, involving the intradiploic space associated with bony remodeling, iso-intense on T1 and hyper-intense signal on T2 flare, with restricted diffusion, with no evidence of any infiltration into the underlying brain parenchyma, and the opinion was left high frontal intradiploic epidermoid cyst. These are the MRI films, and here the lesion is encircled. It shows a well-demarcated high frontal lesion. The same lesion is encircled on another MRI film. And it is hyper-intense on T2 MRI. And so the pathology request form was sent to us by the neurosurgery, and the neurosurgeons underwent excision of the lesion, which was found to be a skull osteolytic lesion, and their provisional diagnosis was an epidermoid cyst. And the specimen was sent to our lab, and the gross description was a fairly defined fibrous tissue piece measuring 3 times 2 times 0.5 centimeters with a grayish-white cut section, multi-sected and totally submitted. Under the microscope, this is the H&E section by low power, which shows a large cell proliferation of large cells with abundant eosinophilic cytoplasm, and an inflammatory infiltrate composed of eosinophils, lymphocytes, and neutrophils. And this is the higher magnification showing the grooved coffee bean nuclei of the larger cells. And the cells encircled are the cells with the coffee bean appearing nuclei. And so immunohistochemistry was ordered, CD1A and S100. This is the result of the S100, and it showed a diffuse positive result in the large cell infiltrate. And this is the CD1A at a lower power, shows diffuse positive membranous staining of the large cell infiltrate. And this is the same for CD1A, but with a higher power. And so the diagnosis here reached was Langerhans cell histiocytosis. And Langerhans cell histiocytosis is a spectrum of clonal proliferations of a special type of immature dendritic cell called the Langerhans cells. There are multiple types of Langerhans cell histiocytosis. The first is single system disease, which can be unifocal or multifocal, and it can be eosinophilic granuloma or isolated skin disease. Eosinophilic granuloma commonly appears as a single lytic bony lesion that usually occurs in children, and isolated skin disease usually appears as rashes. The second category is a multi-system disease, and under this category there is the Latrer-Sewe disease, which is a severe and acute disseminated form, usually occurs in infants under the age of 2 years, and involves multiple organs, including the skin, liver, spleen, lymph nodes, and lungs. And the second disease is Hand-Schüller-Christian disease, which is a chronic multifocal form, and it is formed of a triad of bony lesions, diabetes insipidus, and exophthalmos, commonly occurs in children. And the third category is the pulmonary Langerhans cell histiocytosis, which commonly occurs in adult smokers. Microscopically, Langerhans cell histiocytosis is composed of proliferating Langerhans cells with abundant eosinophilic cytoplasm with nuclear grooving or coffee bean nuclei, and usually there is an eosinophil-rich background. The immunohistochemistry to confirm this diagnosis is the CD1A, S100, and more recently the CD207 or Langrene. And this is an image showing diffuse positive membranous staining by Langrene in the Langerhans cell infiltrate. For the molecular, the BRAF V600E mutation is the most common, which occurs in around 60% of patients, and BRAF inhibitors can be used as a treatment option. This is a study that was done on a cohort of pediatric patients in a Chinese population, and it showed BRAF V600E positivity in about 41% of the cases, which is slightly less than other ethnic groups. And finally, the differential diagnosis for a skull osteolytic lesion. First, we have multiple myeloma. Multiple myeloma often appears as multiple punched out lesions, usually occurs in adults, and it shows microscopically proliferation of monoclonal plasma cells. There's also the option of metastasis, and metastasis usually appears as multiple lesions with bone matrix destruction. It usually occurs in adults, and the pathology is according to the primary site. An intracranial epidermoid cyst is also a differential. It often occurs as a solitary lesion, usually congenital, maybe iso or hyperintense to the CSF or an MRI, and microscopically it is formed of squamous epithelium and desquamated keratin debris. And finally, eosinophilic granuloma, which is a form of Langerhans cell histiocytosis, can appear as single or multiple lesions. It is common in children and young adults, appears usually as hyperintense lesion on T2 FLAIR MRI, and microscopically it is proliferation of Langerhans histiocytes with abundant inflammatory cells. Thank you so much.